Okay, everyone, I think we're about to get started here. Sorry for the little bit of delay. So how were the breakout sessions? Everyone have a good morning and afternoon sessions? Great. Glad to hear. And so now we're going to move on to the panel discussion. So all the speakers that have already spoken today are on the panel, so they're ready to take any questions. What we would ask is we encourage you to ask general questions that others can identify with, rather than maybe like very specific questions to your experience and what you have experienced. Anything like that, maybe you can ask afterward when you have a chance with them. So the other thing is this session is being recorded. So I know sometimes people don't like speaking into a mic, but there's gonna be 2 mics floating around the room. So please speak into the mic so afterwards people that are listening can actually hear the questions that are asked. With that, I'm just going to quickly reintroduce our panel. So we have Dr. Nancy Fu, Clinical Assistant Professor of Gastroenterology at Richmond General Hospital. Gina Almasan, Registered Dietitian at the IBD Center of BC. Kathleen Duddy, Pediatric Nurse Practitioner in Acute Pain Service at BC Children's Hospital. Dr. Simon Lasango, Assistant Professor of Teaching, School, and Applied Child Psychology at the University of British Columbia. Dr. Laura Sly, Professor, Division of Gastroenterology, Department of Pediatrics, and the Faculty of Medicine at the University of British Columbia. And Lauren Wolfe, Certified Wound Ostomy and Continence Nurse at McDonald's Prescriptions and Vancouver General Hospital. So we have a very expert panel here, and so we're ready to take questions from you. So who would like to ask the first question? Someone must have. Okay, right at the front, right here. And we'll just wait for the mic. Thank you.
My question, if this is on or not, doesn't matter. My question is just how much crossover is there in general in your professions from one expertise to another? Because this is really fantastic to be able to come one day and hear and see so many different people speaking. I just wonder how much you can actually talk to each other and if there's any focused agenda for that kind of crossover.
So the question was about crossover in each other's disciplines and in your work. So who would like to take that question first? Okay, and Dr. Nancy Fu will take this question first.
Very good questions. So there are different models of cares, and I think, as you probably have experienced today, is the multidisciplinary care for IBD patients is thought to be the best. But unfortunately, a lot of our cares are in silos, especially in gastroenterology. What has been done, though, is that the IBD Center has tried to bring these support to patients. There has been efforts also to figure out psychologists, dietitians, social worker. We, as a gastroenterologist, because we work in various different regions, and so we would be aware of available services around us. Although we're not under the same roof, but we can connect you to the available services close to us that we are aware of. So it's available, but we're not under the same roof in a lot of settings.
And would anyone else like to add to that on the panel? So we would encourage everyone, if you have a question that's more general, maybe a couple on the panel can answer, but if you have a specific question to someone, if you want to direct your question. But yes, please go ahead, Gina.
So speaking from like a pain or comfort perspective, in the adult world, there's complex or persistent pain that might be addressed, and so your either your primary care provider or your GI specialist could refer you on. If you're at Children's and if it's an acute issue, then they can certainly reach out. I have hallway conversations quite often if there's a child in the hospital. So there are resources there, and we do speak quite candidly. And I know the GI team, although I don't work with them directly.
Great, thank you, Kathleen.
Well, I could say that we're kind of still in the early stages of mental health care and multidisciplinary care, and that there has been recently a big push from psychology around having psychologists in primary care. There's a recent legislative document that was pushed to have support, and I think it was passed. So I think we're still in the early stages, and I'm connected with Nancy, and so we're gonna try to move that agenda forwards. But it comes from your advocacy as well, is your want to see that in primary care.
Great.
So I'm a researcher, and I'm part of the division of gastroenterology. So research is integrated into our clinical division at Children's. And I think we're really lucky when we're dealing with children, because we've just done this huge hospital remodel with really thoughtful integration of systems. So children are at quite an advantage for being able to access and go straight to the place, or in our hospital, the way it was designed, the specific specialties that any specific child needs coming to them within the hospital setting. So it's really quite beautiful, tougher for adults for sure. But I think, one thing that we've said, I think, a lot today is advocacy. Know what you need, don't be afraid to ask for it, and keep asking until your needs are met. You can get a referral from a doctor to any other specialty that you need, and you should actively go ahead and do that. One thing we haven't done very well is mental health yet. That's not integrated into our division directly, and I think that's something we should discuss.
Great.
I'm a little bit of an outlier, but firstly, apology for the coughing. I haven't been well. When it comes to considering a stoma, usually often a last resort, but all your doctors can refer to a stoma nurse. All the hospitals have one, and then there are a number of us in private practice as well. So if there are any questions, you just have to ask your doctor, or you reach out to the United Ostomy Organization to be able to get those questions answered. So although we don't work directly, they can access us at any time.
Great. Thank you.
And I was just going to add, touching on what Nancy Fu said. So, we are fortunate at the IBD Center to be able to offer dietitian and counseling services to our patients. But if anyone outside of the IBD Center is wanting to find and get connected with a dietitian who has GI experience, there is a website called BC Dietitians Network that can help you find a dietitian specializing in what you're wanting support with. So there is an option to filter on that website. So hopefully, if someone doesn't have direct access to dietitian through their gastroenterologist, there are still options in the community as well.
Thank you for sharing that. And yes, living with chronic conditions, there's definitely multi-layered. It's multi-layered, and so it's really nice that we have this event to bring everyone together and provide that advice. So thank you for the responses to that question. Does anyone else have a question in the audience? I see one hand went there, and then we also have one here as well. So we'll
in the next indeterminate amount of years, 5, 10 years, whatever it might be, what is the most promising or exciting thing in each of your respective sort of areas?
who would like to take that first? Sure.
I think maybe just earlier in my breakout sessions, we have talked about a modality that are being becoming more available in North America. So it's something called intestinal ultrasound. Is a non-invasive monitoring modality that I can monitor a patient with Crohn's and colitis without you having to do a preparation, without you having to fast, and is a point of care where you can show up to my clinic and I can put a probe on you and I can tell you whether you have active disease or not. So that's it's available through my clinic right now, but we're hoping to collaborate with the North America IUS, so Canadian Intestinal Ultrasound Group, to try to make it more available for all of you guys across Canada.
So I'd say in the field of nutrition, precision nutrition is definitely up and coming. which really aims to give like personalized advice to an individual for diet based on like genetic components and biomarkers and very specific things to you. So precision nutrition, yeah, really will take into account everything about you and really give you specific nutrition recommendations, whether it's, overall dietary approaches or specific nutrients you need to really target inflammation and symptoms in your specific scenario.
From the the acute pain perspective, some of the non-opioid pharmacological management that is up and coming. So that's really opioid spare is the goal of most pain management. So medications in that aspect, but then looking at the chronic or persistent pain, the really bringing in the mind-body and fostering that in through either self-hypnosis or ways that you can help manage that yourself. And in sort of an acute management or through procedural discomfort would be virtual reality is something that's on the horizon. I know that some of the clinics back east are using that for colonoscopies, and so you're not actually receiving medications. You have virtual reality and no medication and no stated discomfort.
Yeah, I spoke about it a bit in my session, but the incorporation of positive psychology and the conceptualization of disease and symptoms and psychosocial factors, so as opposed to looking at the medical model of vulnerabilities, really focusing on client strengths. And I think something that Nancy and I were just recently talking about was filling in the gap of parent-caregiver support and really understanding and providing more effective support to help youth transition, to help patients and caregivers together.
Thanks. I was listening to everybody and I was thinking, oh, that's the best. Oh, that's the best. I picked that one. Those are all great advances. In the research world, we live in a world of omics. We're doing a lot of looking at genomics, proteomics, metabolomics. And this links to precision medicine in that we're learning enough about the individual and how individual features of your biology are affecting things that I think that we can do some precision medicine. I think we'll be able to predict what the longer term trajectory of disease is going to be for an individual. And then we're going to be able to give them the right medicines at the right time. We won't have to go through long and drawn out processes when you're going through treatment failure. We'll be able to know that something is going to work for you, not going to work for you, and get the appropriate medicines to the right people right off the bat. I think that's our goal in research.
Sorry about this. Really, for ostomy, I can't speak to any surgical things. I'm not a surgeon. But I do know that all the ostomy companies are always looking at improving on the pouching systems, trying to make them less discreet. So that's pretty much all from the ostomy world.
Great. So it sounds like a lot of developments in the pipeline down the road. It sounds like, I like the idea of no probing, no prep for certain diagnoses, and precision nutrition, precision medication, more personalized advice, and positive psychology, all of it. It sounds really great. And I think we had a question up at the front.
Hi. I'm curious to know, there's so many biologics. I think this is probably a question for Drs. Fu and Dr. Sly. So many biologics, quite often a patient will be offered the choice between two different biologics, and it's not always clear why you're being offered a particular option. And I guess I'm curious to know, are there emerging protocols or best practices in terms of offering various treatments, biologics or otherwise, but mainly biologics because of the ever-increasing number of them, to a patient? And do you see that some of those protocols may be changing or emerging? So that's my question. Thanks.
Who would like to take that first? Dr. Fu? Okay. Thank you.
excellent questions. This is something we're also in a process of wrapping our mind around it. As you said, there are lots of biologics becoming available. There are new mechanisms that are also becoming available for all of us. I think one thing that in order to offer the biologics to you, we need to get to know you and your disease well. And depends on where you are in your disease course, there are certain medication that may be perceived to be more effective or not in certain disease course. And that's probably why as a gastroenterologist, instead of overwhelming you with, say, okay, I have 10 biologics for you, pick one, then I might go through my process in my mind and say, okay, for you in this particular situation, whether you have some extraintestinal manifestation, you have luminal disease, you have strictural disease, you have other comorbidities, maybe these are the biologics that I think may be best for you. And that's why many of us that practice IBD would have gone through that process and say, okay, I think the top 3 for you would be these 3. And then we'll dive into discussion regarding these 3 medications. I do have other patients that may be interested in learning about all the biologics, which is totally reasonable. And there are times, and it's virtually, for me at least, it's not expected for the patient to make decision right at the moment when we're talking about biologics. So usually what happens is I provide information and resources for you, and you go and read about it, and we regroup again to clarify your questions, and we make a decision together. So whether, and going back to your questions, like, is there a protocol? I do not want there to be a protocol, to be honest, because as we mentioned about precision medicine, how each patient's disease is different, and how for me at least, it will be an important to discuss what may be the best medication for you, as opposed to, oh, you have X, Y, Z, and you should be on this medication. Does that make sense?
Thank you.
Can I just add a
Yes.
little bit of history? So just a little bit of history, because I think it's pertinent. So I'm not a practitioner. I'm a PhD scientist, so my PhD in interpretive dance is not helpful, but my PhD is actually in immunology. So what happened maybe 5 or 7 years ago when the anti-TNF came off, the anti-TNF antibodies came off patent. And it was maybe 5 or 7, do you know? Yeah, and so that means that somebody had held a patent and they made a lot of money on those drugs for a certain amount of time. And when that patent expired, a bunch of biosimilars came out. And we were really nervous at first about that change process because, the government is going to pick the cheaper drug if they're going to pay for it for you. Some people will have medical plans that will pay for the original brand name. So we got flooded with a lot, and we didn't have long-term data on it. We were really nervous about how this might affect patients at that time. And it went way more smoothly. Like we were imagining, hoping for the best, but planning for the worst. So there's 2 things that have happened. Things came off patent, and a lot of things became available. And they've been highly effective and comparably effective so far. Things are looking really good. So that was a really good thing. Another thing that's happened is the research has progressed. So we don't only have the anti-TNF biologic. There's things that stop cell trafficking to the gut. There's things that are blocking different inflammatory pathways as opposed to blocking an inflammatory molecule, and that's the JAK inhibitors. And they're all very effective. The safety profile is good. Some of them have a little bit of restriction on when they can be used, but there's lots of good options now. So that's why there's so many options, whereas 10 or 15 years ago it used to be, this is the drug that we'll put you on. And it's because there's been so many advances and improvements. So there's a little bit more selection and more choice, and some of them are a little bit finagly about what they're better at. So sort of sorting through that still, but things are looking pretty sunny.
Thank you for adding that context, Dr. Sly, and thank you, Dr. Fu. It sounds like it's definitely a consultation with your patients, which is always nice when patients can better understand what they're going on to in a transition phase. Great. Does anyone else have a question? I see a question there, so we'll go there first, and we also have one here that can follow.
Hi. I was just wondering, can you hear me?
Yes,
Yeah.
it's good.
I was just wondering, over the last year or so, I get notices from Crohn's and colitis about new research and projects that have come out. And the disturbing thing that I've noticed is a rise in Crohn's and colitis in infants. And this baffles me too, to see a rise in young children at a time when I would have thought that children have much better access to nutritional advice, to organic foods, things like that. Can any of you speak to these issues as to why this surge?
Also, Dr. Slice, sort of where research is starting, because what we have seen a trend is environmental factor is playing into a big part in terms of increase in IBD diagnosis. I think Dr. Kaplan in Calgary has done some research in this. So microbiome is the big word here, that because of the changing environment, changing food sources, as you mentioned, and maybe modes of deliveries that we are exposed to a different host and microbiome interactions. That may change how IBD and our immune system respond, and that's maybe a reason for us to see more of a diagnosis of IBD in young infants. That's my understanding.
Just to sort of go on top of that one, would you find that there's populations like that are having an increase in diagnosis?
So what we're seeing is then the Asian and South Asian area. But was to do is also again environmental, so industrializations and use of antibiotics and changes. That's when we are seeing the biggest peak of diagnosis in Asian and South Asians.
And I think if I remember from this morning, Dr. Sly, in your presentation, you had shown, I think, 80 to 100 child diagnoses a year at Children's Hospital. Is that right? So, yeah, I guess there's definitely an alarming increase in some of the youngest populations. Yeah. Thank you very much for the question and the answers. And we had a question. Yes, please.
So I'm going to jump on that because I have a child with IBD. So what do you think are the key differences that we need to take note of between pediatric care and adult care for IBD?
So we had a discussion about transitions. There are various different approaches, like what Dr. Slide had mentioned. Pediatrics system is resource rich. So as she mentioned that, can have access to multidisciplinary care a lot easier as opposed to adult care. So we're working on the adult care side to try to see if we can help provide and help better our resource for people that are transferring or transitioning over to the adult care. There are quite a bit of difference, and there's there are lots of gaps and lots of potholes along the trip. So we're trying to help fill the gaps and smooth out the road so that when people are moving from pediatric to adults, it will become easier. It's a big project that we're working on. We're working on a multidisciplinary care models, and it's a multi-center study across Canada. So hopefully we'll have an answer for you maybe in about 2 years.
the transition clinics are amazing, and they did not exist when I started in the IBD research world 15 years ago. And basically, a kid graduated from BC Children's Hospital where they had this holistic approach and a holistic approach to their care and everybody surrounding them, and then they just kind of got thrown out in the community, and it was traumatic. And they have done the clinicians involved in transition care have done such a great job making that transition. And there is a turning point for kids where they have to start taking responsibility for their health, for their well-being, for their own care, and know what their needs are and learn to advocate for themselves. Their parents and doctors will have done that earlier on. So it's a really important time. Transition is a really important time. And as Matthew mentioned earlier, a time, I think it was Matthew that mentioned a really important time for children in their growth and development as young adults, so much going on in their lives. So hopefully that is getting better and better all the time. And by the time your daughter is ready to transition, I think it's going to be a better world.
Great. Thank you for that question. I think there's a follow-up.
If I may.
Go ahead.
Thank you for the transition part, and I'm excited that she has time to get to that point. What about the treatment, though? What are the key differences in the treating of children with IBD versus adults today?
I think one thing is that treatment, I guess investigation is a little bit different, availability in terms of investigations, and the goal can be a little bit different. So as I kind of discussed in the sessions, for young pediatric patients, the goal is to get them growing, get their nutrition in, for them to reach the growth peak that they need to get to. But as for adult side of things, what we're hoping to do is to prevent complications and help them, not getting and not ending up having surgeries or try to change their disease course. That's kind of the goal difference. So having that in mind, we use medication maybe a little bit differently. So in pediatrics, a lot of enteral nutrition, feeding, trying to get their nutrition in, and then medications perhaps moving forward. But on the adult sides, we do use medications earlier and maybe a bit more aggressive in some way. Availabilities on medication may be different too. So our pediatric colleagues unfortunately only have probably 3 or 4 drugs available to them. But on the other hand, I have a lot more options that in my pocket that I can use for my patients. So often there's discussions, and I often have lots of discussion with our pediatric colleague, Dr. Lawrence, Dr. Foster, and say, okay, well, this kid is young adults, but maybe can we try some of the adult medication for them? There are times that these examples or these exceptions happens, and because their disease are sick, they're sick. So.
Great. Thank you very much for sharing that. More questions from the audience? Yes, right in the middle. Oh, just sorry, 1 second. We'll have to speak into a mic just because they won't hear you on the camera.
I was just wondering, in the classroom, we practice a lot of mindfulness for young students. Do you have any recommendations for how we can support them if they might be going through an episode or any sort of pain?
Dr. Lisango, do you want to take that one?
Yeah, I think that research is still emerging. There's nothing specifically that I found specific to IBD. Personally, there is a resource called The Healing Power of the Breath by Richard Brown and Patricia Gerbarg, who've done some mindfulness training for people with chronic illnesses. And so, anecdotally, it's something that I practice, and the same with pain management. There's some self-hypnosis type mindfulness practices or meditation tracks in there that can help alleviate pain.
Sorry, you said Richard Brown?
Richard Brown and Patricia Gerbarg.
Thank you. And Kathleen, you.
I just want to add it from the pediatric perspective. If you do have a child who's 18 or younger, there is a mind-body program at the Children's Hospital to help facilitate that. It's complicated when you're a child to kind of grasp those concepts. So there is a really very established program through the mind-body work there.
Great, thank you for sharing that. So that was mind-body program. Perfect. Thank you. Great. And another question. We have a question right here in the front, Marco here. And just put your hand up again, please. Yeah, there we go. Thank you.
Thank you very much. In my case, I've been adding autoimmune diseases to my what is called now ulcerative proctitis. So I have thyroid issue, I have esophagus issues, I have bone issues. So I'm wondering, what does that mean for a person? Like, I've been sick for 40 years. Does it mean that I keep adding those autoimmune diseases until I leave? Like, what's happening?
Tricky questions. Okay. I think perhaps going back, maybe hard to answer the questions. Perhaps there is some genetic predispositions in this case, because we know that a lot of autoimmune conditions do overlap, and that's why we use also similar medications with our rheumatologist, right? So autoimmune, like Crohn's and colitis, overlaps with rheumatoid arthritis, thyroid disease, Graves, and so we have these overlaps, and that perhaps coming from sharing similar genes, and and we also see from the GEM projects that there are perhaps familial lineages, and so that's where all kind of things come together, that perhaps you may have a predispositions in terms of autoimmune condition. That's where it comes in.
Thank you. Yeah, I guess everyone's experience is very different. So yes, thank you. Another question from the audience. I don't know if anyone on this side of the room has a question, or at the back. Yes, in the front here, Gurpreet.
I have a question about once you're on a biologic, is the accepted view that you remain on that biologic regardless of being in remission or not being in remission until that biologic no longer starts working? And from a patient's perspective, that's a tiny bit hard to swallow because you want to get off these drugs as soon as you can, but you're being told, no, stay on them. Is that still the current thinking?
I think there are two parts of the answers to you. So we have, in terms of being on a biologics, if you're in remission, we would prefer you to stay on medication. The reason being that knowing you have an autoimmune condition, being on biologics, if you come off the medications, your immune system may wake up, and then you may run into issue with flares. The old school training is that a lot of the biologics are protein molecules. So there are chances of your body developing autoantibody to these molecules. And so that the moment you have a drug holiday, when you go back on the medication, there are potential risk of you not responding to the medications, or you develop resistance to the medication. And that's when we are encouraging patients to stay on medications, even when you're not having active disease, you're in remission. Now, have that in mind, we are launching into an era of small molecules, which is not a protein molecules in your body. And so your chances of your body developing resistance to these medication is 0. Right? So it's like you're taking Tylenol and you don't have headache, you stop taking Tylenol. Similar situations now, that's where we are. There are certain molecules, there are small molecules that are treating Crohn's and colitis. And perhaps we're gonna be able to see kind of the light that, okay, well, I guess you come on medication and then you go back on medication and come on medication, go back on medication, and I don't have to worry about you developing resistance. Does that answer your question? Okay.
Yeah, thank you.
Thank you for that. Another question. Anyone? Yes, right in the front here. Thank you, Michelle.
I like to ask these sort of broad questions to give everyone an opportunity. What's like the biggest myth or misconception or thing that you're really tired of hearing about in your field that you want to try to dispel right now for everyone?
I think there's a misunderstanding that irritable bowel syndrome is similar to inflammatory bowel disease, and I see people using the term IBS and IBD interchangeably, and that.
Yes, that's a good point. And at an organization level, we experience the same thing at Crohn's and Colitis Canada. Yes. Gina, yes.
Yeah, so I'd say like blanket recommendations of say like all patients with IBD should be avoiding dairy and gluten and various other categories of foods. I think each individual is, their food triggers are so specific that what might work for one person might not work well for the next. And I think with some of those areas like gluten and dairy, we're not necessarily at the point in research of being able to say for sure whether these things are highly inflammatory in all individuals. And so I'd say, precision nutrition is, hopefully we'll get to that point of giving more tailored advice, but for now, be careful of these blanket recommendations that people are giving.
Great, thank you for that.
I think for me, in the opioid crisis that we have, and working with families of children, the worry that prescribing opioids, which I do on a daily basis, that they will become addicted. So just knowing that if opioids are prescribed, in particular for children, it is very much a short-term, very mindful prescription, and they will not become addicted because we take them off very carefully. And then the adult world, I can't speak to. But for pediatrics, opioid sparing is the language we try to use.
Thanks, Kathleen.
And I'll bring it back. I mean, I would give you the opportunity to share what you shared with me around, but I would say it's the medication as the answer. Medication for psychosocial functioning, anxiety, depression is not the only answer, and that we don't have good efficacy for just medication alone treating anxiety or depression, and that therapy with those medications can be helpful. Medications help dull some effects of activation, but ultimately you need to work through that. And it's not only therapy, that therapy is not the only answer to anxiety and depression. There's a multitude of things you can do, from peer support, from self-fulfillment, from building your own resilience, so social support. There's a whole plethora of things around your environment that you can do to support mental health and wellness.
Thanks for that.
I think this is hard in the research world. I think that people need to stop thinking about inflammatory bowel disease or Crohn's disease and ulcerative colitis as one disease. There are probably many versions, and there are many versions dependent on, like some people might have a subgroup of disease. And the fact that, we've done ourselves a little bit of a disservice by lumping all of these diseases together. I think the gut is a very sensitive place in the immune response. This is like the canary in the coal mine. And you have a lot of ways that you can get there, and they need to be addressed separately, very differently in different people. So I think the answer to the multi-disease problem, like it's a disorder of the gut, and there's probably many causes and many ways to get there, and we need to start digging into what is important for individuals.
Thank you.
So for me, it's pretty easy because I think most people in the room who don't have an ostomy don't want an ostomy. And I think that's the biggest challenge we face. Having an ostomy is not bad. And if you'd come to my presentation, you would have heard 3 speakers, individuals with ostomies, speak how much their quality of life have improved with an ostomy, and they'd wish they'd had it sooner. So for me, the biggest thing to change is perception, is that when you need to have an ostomy, it is not the worst thing. Don't listen to the media of the celebrity who had a very bad experience because he didn't have a good stoma nurse or a good team. And that there are many people in the room with you today who have ostomies who live an absolutely normal life. And it's not the worst thing you could do.
Yes, a very important reminder. Thank you, Lauren, for sharing that. Maybe I'll interject here just to ask a more specific question to Gina, because when we hold our support groups, and I'm sure some of the volunteers at the back know very well, diet is always a big question. And so you talked about gluten and lactose. And so maybe, I know you touched on it maybe in some of your presentation, but what would be your best advice to people that live with Crohn's or colitis or recently diagnosed on how to identify the trigger foods?
So I'd say, first of all, food triggers can be pretty challenging to determine in times of flare-ups for some people because there's so many things at play, including inflammation, that can impact symptoms. It's not necessarily just diet. So that can be a bit of a tricky time. I'd say remission can be a bit of an easier time to determine, in some cases, food triggers. And one thing that I do sometimes recommend is keeping a food and symptom journal, whether that's over a few days or a week or more, just to see if there are any trends that you can identify between when you're eating different types of foods and when you're getting symptoms. Sometimes symptoms can be quite delayed after a meal. So I guess it can make it a little bit more complicated. But I do also want to say about timing of symptoms and diet. For some people, if they're getting symptoms right after a meal, usually what's coming through, if you're having a bowel movement right after a meal, it's not what you just ate already appearing in your stool. It's probably what you ate 1 or 2 or maybe even 3 meals prior. But there is that motility and movement and contractions after meal to push things through that patients might be noticing. So a food and symptom journal can be helpful, even more helpful if they can dive into looking at the food and symptom journal with a dietitian who might be able to kind of identify more than maybe the patient can. But yeah, that's one way. I think for some people, identified food triggers might look like, maybe you suspect there's a few different foods that you're reacting to. Maybe you remove those few foods for a few weeks and just see if you notice symptom improvement. And then from there, introducing one at a time, starting with small amounts just to see if symptoms return. Because the goal is, having the most varied, liberalized diet possible while still managing symptoms. So if you are experimenting with taking foods away, trying to add those back in, even if it's small amounts, just to see if symptoms return.
Great. I think that's good advice, and it's a common question that I know we experience. So thanks for the information. I think we're coming close to the end. So if there's maybe a question to ask, does anyone have a question? No more questions. Yes, please, Marco, go ahead.
I might have one. So with all developments right now, we are exploring more about microbiome, about genetics and everything. So we are potentially seeing more and more risk factors that could, bring person to develop either Crohn or colitis. So is there any development in kind of preventative care in a way of we see there is high risk for this person, and can we do something before that person kind of develops the disease?
Anybody want to take that on related to preventative care?
Unfortunately, no. I think that for the first time, we've got some big patient groups and we've got some big data sets where we can start to really make those connections. But whether or not we can intervene is the next step. And I think we're just getting those great insights now from studies like the GEM study. And I hope that that's the future that we're moving towards. But I don't think that there's anything that we can say right now.
Yeah, and I think that's a good point, and it kind of goes back to the GEM project and trying to figure out what's the cause, right? We don't know the cause, we don't have a cure, so it's still trying to find that out. I think that's great perspective. Thank you, Dr. Sly. Thank you. I'll just wait 1 second here. If anyone has a last question, anyone have burning question that they didn't get a chance to ask? Okay. Seeing none, I want to say thank you to our fantastic panel today. Let's give them a round of applause. On behalf of Crohn's and Colitis Canada, thank you for being here and sharing your expertise with all of us. We greatly appreciate it. I also, while they take a quick photo, I'm going to say also a thank you to all of the booth guests. And I know lots of you had an opportunity to go in those booths and talk to the experts as well. So we also want to say thank you to our volunteers. I believe they're at the back there. So if they want to give a wave, thank you very much to our volunteers. And our staff, of course. Our staff, there's Susan and Michelle here, Terry at the back, and Sarah was with us earlier today too. So thank you to the staff. I would also like to once again thank the generous sponsors of today's event, George Pick and Santi Pelias, and I'd like to please ask both of them to come to the stage now. And I would like to invite George to say a few words for all of us.
Well, good afternoon, everyone. And I'm not going to go on for very long. I would just like to thank you all for coming out and recognizing how important having a symposium like this is, and also recognizing that we haven't had one in, I think, the last 6 years, has it been, Susan? And the last time I attended something like this was probably 15 years ago, and I can't believe how far we've come in just the space of the last 5 years. So I'm looking forward to hearing more, seeing more, and thank you so much to our panel. You were really, really wonderful. Thanks very much.
Before you leave, George. So before they leave the stage, if you completed your passport, hopefully it's in here. Does anybody have a straggling passport they'd like to add before we draw? No? Okay. So I'll ask each of you to pick a name. And let's just make sure there's one. Perfect. Okay, so we have 2 winners, and at the end you can come pick up your basket. So the first one is Summer Johnson. Summer here? Perfect. Thank you. Congratulations. So at the end, we'll get you to come up and you can pick up the basket, the survival kit here. And the second winner is Mohammed Ramatullah. Mohammed. Oh, perfect. So yes, at the end, congratulations. And I want to say again, thank you, George and Santi, very much. We just have a small thank you for both of you.
That's very nice of you. Thank you
yes.
so much.
Thank you very much. Thank you. Yes, and we are very grateful to have education events like this. And as George said, I think the last time we had something like this was in 2018. So it's been a while. So I do hope you were inspired by some of the research and some of the innovations that are in the pipeline of all the disciplines that we've talked about. But Crohn's and Colitis Canada is investing in research that even Dr. Laura Sly talked about this morning. So the event was completely sponsored, which we appreciate a lot. But if you are able to make a donation today, there is going to be a donation box in the atrium. We have over 100 people here today, so even if everyone just did $10, we'd raise over $1,000, which will go directly to research. So we ask you to consider that, and every dollar does count. Also, after the event, you will receive an online survey. Your feedback is important to us, and so please share any constructive feedback, even maybe what types of topics you want to hear about again or hear about in the future. And we'll make sure to include your feedback in future event planning. So thank you very much. Finally, I want to thank each and every one of you for being here today on a Sunday to learn, share, and ask your questions. I think we all deserve a round of applause for ourselves. And for those that are impacted by IBD, whether it's you yourself or a loved one, know that you're not alone. And we encourage you to check the website crohnsandcolitis.ca to look at programs, events, and opportunities to get involved. Crohn's and Colitis Canada's promise is to cure Crohn's disease and ulcerative colitis and improve the quality of life of everyone affected by these diseases. And with your help and the support of amazing health professionals and researchers like the ones that we had today, and the work of volunteers across the country, we can be hopeful that we will accomplish that mission. And that will close off today's symposium. I hope you found our event useful. If you'd like to get more involved with Crohn's and Colitis Canada, please see any of the volunteers, staff, or even myself after the event. And once again, a big thank you to George and Santi, to our speakers and the volunteers. Thank you, everyone, and have a good evening.